Great. Thank you very much, Dr. Goldenberg. We'll get started here. So what I want to go over today is a little introduction, go over some of the renal cancer genetics, which is the basics for understanding targeted therapy, look at the role for a cytoreductive nephrectomy, do a brief overview of immunotherapy and sort of where we're at today with immunotherapy, talk about some of the large published trials on targeted therapy, and finally just sum it all up and look at some of the future directions in the field. So in Canada, in 2007, there were almost 5,000 new cases of renal cancer diagnosed. About 1,600 patients will die from renal cell carcinoma in 2007. It's the sixth most common cancer diagnosed, the 10th most common cause of cancer death. And in BC alone, they're estimated to be 500 new cases in 2007. So looking at the incidence and mortality, this is data from the SEER database in the US. Of course, skipped a slide there. Looking at the presentation of renal cell carcinoma, of course, there's been a considerable shift in the presentation. Over 70% of cases present incidentally now following imaging for another reason. Less than 5% present with the classic triad anymore. The stage at presentation, 20% will have locally advanced or nodal positive disease, and 20 to 25% will actually present with metastatic renal cell carcinoma. So looking at the incidence and mortality, this is again from the SEER database. The incidence of localized cancer, localized renal cell cancer has been increasing over the past 20 years, which you'd expect from the changes in imaging. The incidence of metastatic renal cell carcinoma has been decreasing. Despite this, there's been an increase in mortality in these cancer patients. And this tells us that something's changed about the tumor biology of renal cell carcinoma. Despite the fact that we're catching it earlier, patients are still dying from it and actually more likely to die from it now than they were years ago. Looking at the survival of these patients, this is data out of Memorial Sloan Kettering looking at their study patients over two different eras. There's the pre-1990 era and the post-1990 era. You can see that the survival curves have barely changed despite all the advances in medicine over the past 30 years. Median survival is still about 12 to 24 months depending on their risk group. Risk factors, just briefly, smoking and obesity from this meta-analysis have both been proven pretty conclusively to be a risk factor, meaning they're dose dependent. Risk markers have less of a clear association with renal carcinoma. Familial syndromes associated with renal cell carcinoma that we'll talk about a little bit in the genetics section, von Hippel-Lindau disease, hereditary papillary renal cell carcinoma, Birt-Hogg-Dubé syndrome, and hereditary leiomyomatosis in renal cell carcinoma. And finally, just to review the prognostication, this is a model created out of Memorial Sloan Kettering again, covering over 600 patients with metastatic renal cell carcinoma. In this multivariate analysis, they found 5 factors that were significantly predictive of someone's outcome. They include no prior nephrectomy, someone with a Karnofsky performance status less than 80, someone with anemia, hypercalcemia, or an LDH greater than 1.5 times normal. And using these risk factors, you can stratify people into 3 different groups with significantly different prognosis at time of diagnosis. So moving on to renal cell cancer genetics. We'll start with clear cell cancer, the most common subtype of renal cell. The VHL gene was discovered in 1993 and was one of the first advances in the field of understanding renal cell cancer and metastatic renal cell cancer. It's an autosomal dominant gene that's inherited on chromosome 3. And the important thing about this gene is that as well as being mutated in the VHL syndrome, it's also mutated in the sporadic mutations in the person who shows up with renal cell cancer without a familial syndrome. So almost 50 to 75% of these patients will have a mutation in this gene. The VHL syndrome, of course, associated with hemangioblastomas of the CNS, retinal angiomas, and pheochromocytomas, as well as some other rare associations. So looking at the understanding of sporadic versus familial clear cell renal cancer, sporadic cases follow the classic 2-hit hypothesis for development of cancer. you have 2 copies of the VHL gene. 1 copy is mutated, a second copy is mutated. Additional things happen, and it leads to the development of a single tumor. In von Hippel-Lindau syndrome or disease, you inherit 1 defective gene right off the start, so you're much more likely to develop early and multicentric renal tumors. The VHL protein itself is a tumor suppressor gene. It's produced in cellular response to hypoxia. Loss of this gene or this protein product results in accumulation of HIF1. This leads to increased VEGF, which leads to angiogenesis, increased transforming growth factor, which leads to cellular growth, increased GLUT1, which leads to increased glucose uptake, basically all factors that are required for neoplastic growth. A quick schematic just looking at the activity of HIF alpha. So in a normoxic state, HIF is going to be hydroxylated with the presence of oxygen in the environment. The normal VHL protein will be able to bind to this, form a complex which targets HIF for ubiquination and subsequent proteasomal destruction. However, if you have a mutated protein or if you're in a hypoxic state, then HIF1 does what it's meant to do, which is basically translocate into the nucleus and cause transcription of VEGF and other pro-growth factors. Moving on to papillary renal cell. So recent cytogenetic studies have subdivided papillary cancer into type 1 and type 2. Understanding of type 1 is mostly based on families with hereditary papillary renal cell carcinoma. The gene identified in this is c-Met on chromosome 7. In contrast to VHL, this one's actually a proto-oncogene, and it encodes the tyrosine kinase membrane receptor hepatocyte growth factor. Again, because this is a proto-oncogene, it's actually a gain-of-function mutation, not a loss of function. So the MET gene, in a sporadic case, undergoes an activating mutation. The chromosome it's on is duplicated, and you develop additional mutations in a single tumor. Now, most sporadic cases of papillary type 1 renal cell carcinoma actually do not have the mutation in the MET gene. In patients with hereditary papillary carcinoma, they inherit the activating mutation right off the bat, so they're much more likely to develop the early multifocal tumors that are seen. Oncogenic mechanisms for papillary type 1, it activates key oncogenic pathways, it leads to angiogenesis, and increased protease production leads to cellular dissociation, leading to metastases. Again, a quick schematic just showing that in hereditary papillary renal cell or the occasional sporadic renal cell, the hepatocyte growth factor receptor encoded by the MET gene is basically upregulated and leads to a disproportionate response to binding of its ligand. Papillary type 2, understanding of this is based on hereditary leiomyomatosis and renal cell carcinoma syndrome. The mutation is actually in fumarate hydratase, one of the enzymes in the Krebs cycle. The association, again, is with a type 2 papillary renal cell, which is a more aggressive form of papillary renal cell, as well as with cutaneous and uterine leiomyomas. Chromophobe, understanding of the genetics of this is based on Birt-Hogg-Dubé syndrome. It's also a tumor suppressor gene that encodes folliculin. Okay, we're done with the boring stuff. Sorry about that. Summary. So looking at proximal collecting tubule genes, or proximal collecting tubular cancers, clear cell and papillary, they're the most common. The important thing to note here is that clear cell cancer, the most common one, does have the genetic mutation in the VHL gene in 50 to 75% of the sporadic cases. So this really gives us the evidence we need for targeted therapy and really directed therapy down the VEGF pathway initially. Yep. You can. The question from Dr. McLaughlin was whether or not you can test for it. I'm sure you can, because most of the. No, I don't think it's really applied clinically. I think in syndromatic patients for query VHL syndrome, it is tested for. So moving on to the next topic, cytoreductive nephrectomy. So we'll get into some good stuff here now. Interest in cytoreductive nephrectomy is mostly due to a few factors. There's poor outcomes in metastatic renal cell carcinoma, as we saw from the introduction. The metastatic renal cells generally chemo-resistant. A review of over 3,500 patients treated with a variety of chemotherapeutic regimes showed an overall response rate of about 6%. This is due to the multi-drug resistant protein that's produced within metastatic renal cell carcinoma. And in summary, there's basically been no good medical therapy for this metastatic disease. Previous arguments for doing a cytoreductive nephrectomy included to treat hematuria refractory to embolization, to palliate pain due to tumor necrosis, to induce a spontaneous regression, which on review of the literature there have been hundreds of reported cases, but the incidence is probably around 0.7%. And finally, to create a temporary improvement in a paraneoplastic syndrome that is basically refractory to medical management. So why would a cytoreductive nephrectomy potentially help cure the disease? There are a couple different hypotheses that have been suggested. The first one is a rather simplistic view, basically saying that you're reducing the disease burden and you're resetting the clock for a time to a lethal disease burden or to lethal number of metastases. Second hypothesis is that removal of the renal unit actually leads to mild renal failure and acidosis. It's well known that tumors acidify their microenvironment to deal with intracellular acidosis from relative hypoxia. If you have a systemic acidosis, it actually makes it harder for the tumor to do this. And leads to a reduction in tumor invasiveness and growth. And actually a group did a retrospective review of patients treated with cytoreductive nephrectomy and found that those with a higher creatinine or bun after their cytoreductive nephrectomy did better rather than the group with the lower creatinine and bun, which would be kind of counterintuitive. These two hypotheses are probably more mainstream and more likely to be true. Third one is immunoregulation. So the view is that the tumor is actually immunosuppressive. And it's been demonstrated in several basic science studies that renal cell carcinoma does actually cause some impaired immune surveillance, and that some of these deficits are reversed with nephrectomy. And finally, angiogenesis. So the view is that the primary tumor secretes growth factors that promote metastases, and they've demonstrated upregulation of several of these growth factors, such as VEGF and transforming growth factor. So the preliminary evidence for cytoreductive nephrectomy was based on several retrospective reviews. The problem with these were they all had an uncontrolled interval between nephrectomy and systemic therapy, and the question was, and none of them were randomized, so the question was, are you simply selecting patients that are going to respond to immunotherapy by selecting patients that are good surgical candidates? The question was further investigated with some high-quality randomized trials in the 90s, and provided us with some good quality level 1 evidence to base our clinical opinions of cytoreductive nephrectomy on. So these two studies were published in 2001 in the New England Journal and Lancet. The first one was carried out by the SWOG group and looked at 241 patients. The second one carried out by a European group and looked at 85 patients. And the basic design of the trial was to randomize patients to either interferon alpha alone or cytoreductive nephrectomy plus interferon alpha. So in order to apply these trials to our practice, we have to understand what kind of patients they included. The inclusion criteria is basically any sort of primary tumor, any sort of primary renal cell carcinoma that was biopsy proven. It had to be judged resectable by the operating surgeon. The patient had to have had a good ECOG status, so basically 0 or 1, 0 being fully functional, 1 being limitation to strenuous activity only. They had to have adequate medical conditions, so good pulmonary and cardiac reserve, no previous systemic therapy or radiation, no other invasive cancers in the last 5 years. So the first question and the biggest argument against cytoreductive nephrectomy is it safe? Traditional reports in the literature quoted a mortality rate of anywhere from 5 to 20% in these patients. In these two trials, the overall death rate was 1.5%. There were 2 deaths in the operative group, both of them post-operatively. One was from post-operative dehiscence and intra-abdominal abscess. Another one was from progression of the disease in the post-operative period. So in terms of intraoperative deaths or deaths directly related to the surgery, it was pretty minimal. 75% of patients had no surgical complications whatsoever, and severe complications occurred in only 5% of patients. And these were primarily infection or cardiac related. Mean hospitalization, 8 days. and only 5.6% of patients were unable to proceed to immunotherapy after for medical reasons after the nephrectomy. So the majority of the patients are still able to go on to their systemic therapy. So the two studies actually used identical inclusion criteria and identical selection criteria. Therefore, the results were able to be combined, and the combined analysis was published in the Journal of Urology in 2004. This is a Kaplan-Meier curve of overall survival. You can see the solid line represents nephrectomy and interferon alpha. The dashed line represents interferon only. So there was a significantly improved survival in the nephrectomy and interferon alpha group. Looking at the results altogether, the survival advantage was approximately 5.8 months in the group treated with cytoreductive nephrectomy and interferon alpha. There was a 31% reduction in death in this group. Dr. McLaughlin?
How many months were in the hospital?
Pardon me?
How many months of that 5.8 months were you in the hospital?
The question was how many months did the patient actually spend in hospital? And that's a good point. It doesn't actually specify in the trial how long they were actually, like their quality of life in this group. I'm not sure if they had improved quality or not, quality of life. The best responses were seen in what would be hypothesized to be the best risk patients. So ones with ECOG 0, pulmonary Mets only, or minimal disease burden. And this was shown to be, and the cytoreductive nephrectomy was shown to be beneficial across all subgroups. So all patients do respond or do benefit from some degree in this group. In the combined analysis, only ECOG status 0 was found to be significantly significantly predictive of a better response. So what does this tell us? Basically, this tells us, gives us a starting point in terms of cytoreductive nephrectomy. It's proved the efficacy of cytoreductive nephrectomy. It's a little disappointing to see the survival advantage only being about 6 months, but it does make it hard to argue for more placebo-controlled trials with this kind of conclusive data. Some groups have hypothesized that there may be a better response with different systemic therapy. We'll talk about some of the newer systemic therapies coming up, but of course interferon alpha is probably one of the least active agents that we have now. A retrospective review was carried out at UCLA, and they basically went back in their database of patients with metastatic renal cell carcinoma, found people who fit the SWOG inclusion criteria, but were treated with interleukin-2 instead of interferon alpha. And they found the median survival in this group was 17 months. This is significantly better than the median survival of 12 months in the nephrectomy plus interferon alpha group. So this gives us some insight into the fact that, better systemic therapies may actually widen this survival advantage. So the next question, of course, is what about in the era of targeted therapy? And there are two schools of thought, basically the evidence-based medicine school of thought and the medical nephrectomy school of thought. The two large RCTs that give us the evidence for sunitinib and sorafenib included patients in which over 90% had had a cytoreductive nephrectomy. If you follow a pure evidence-based medicine perspective, you've got to apply these trials to the same population. Therefore, this would make the argument that in order to use these drugs for their assumed indications in these trials, the patient should have a cytoreductive nephrectomy first. This is countered by the people who believe in targeted therapy and show the follow-up CTs of patients treated with sunitinib or sorafenib, which demonstrate significant reduction in both the primary and the metastatic lesions. Thus questioning, if you can control the lesion, you're still not curing patients, so why bother with putting them through the invasive surgery? Why not simply control the primary and extend their life with the targeted therapy? Now, whether we're ever going to get a conclusive answer to this is difficult to say. It's difficult to repeat a randomized controlled trial now with an arm that doesn't include nephrectomy due to the ethics given the evidence that we have and due to the limited number of patients with metastatic renal cell carcinoma. They're probably better investigated in randomized trials with newer targeted therapy or combination therapy rather than sending them down this path. So some further points about cytoreductive nephrectomy. Obviously, if this can be done laparoscopically, this would be even better. You've minimized their morbidity. Several groups have looked at that, and basically the candidates would be patients with no local invasion, a tumor less than 15 centimeters, no venous thrombus, and minimal hilar adenopathy. These are three groups that published their results in patients with metastatic renal cell. You can see the first group done in the in the late 90s had a significantly longer operative time than we're used to. Subsequent reports from Cleveland Clinic and MD Anderson, obviously with very talented surgeons there, had OR time of about 3 hours and demonstrated that the benefits of laparoscopic surgery that we do for curative intent are maintained in these patients, namely minimal blood loss, decreased hospital stay. Nephron-sparing surgery, indications for this in metastatic renal cell would basically be the same as patients with a non-metastatic renal cell carcinoma, so someone with a solitary kidney, with bilateral disease, with renal insufficiency. And it's important to consider this in the treatment modality because impaired renal function will limit their admission to clinical trials and may limit their subsequent therapeutic options for systemic therapy. I'll talk just briefly about surgical management of metastatic disease. Justification of this for renal cell carcinoma is based on case reports with long-term survival, especially with solitary mets, up to 10 years. So essentially curing the patient by managing their primary and metastatic disease with surgery. The best response rates and the primary indication for this still involves the ability to completely resect pulmonary mets with a 5-year survival of about 40 to 50%. These are some of the larger studies that have been published looking at metastatic renal cell carcinoma and their metastatic disease. We'll talk about lung mets first, obviously the most common site of mets and the best chance for cure. If someone has a solitary metastatic lesion in the lung, chance of cure with that with a 5-year survival rate has a 5-year survival rate of approximately 45%. So those patients do have the possibility of cure. Multiple metastatic lesions, that's a 5-year survival drops down to 25%. You can see some of the prognostic factors there. Complete resection, and obviously anything that suggests minimal disease burden, such as a small lesion, no focal lymph nodes. Bone metastases, these are primarily treated surgically for palliative reasons, either for pain or to increase someone's functional ability. Brain mets have a very poor prognosis and again are primarily treated for palliative reasons due to bleeding and are mostly treated now by stereotactic gamma knife radiation. Liver mets, almost 100% of patients with liver mets will have metastatic disease elsewhere and have a very poor prognosis. Again, surgical management in these patients would be extremely rare. Several groups have looked at other factors that may predict a worse outcome and sort of try to guide which groups should and should not have cytoreductive nephrectomies. There's been a report published that if you can remove over 90% of the functional volume of the tumor burden, you're going to have a significantly better outcome than if you can only remove less than 90%. So basically looking at the ratio of disease burden in the primary versus the metastatic sites. If you only have one organ involved with mets, you're going to have a better outcome. If you have nodal negative disease, you're going to have a better 5-month or have a better survival at 20 months versus 10 months with nodal positive disease. A group looked at the T4M1 group specifically, and these patients tend to have a very poor prognosis. And finally, pathological cell type. So clear cell tumors are going to have a significantly longer survival versus non-clear cell tumors. Just talking a bit more about the histological factors predicting outcome. So clear cell histology obviously is going to be the major or the best prognostic group. Most clinical trials are primarily clear cell patients, including the cytoreductive nephrectomy trials. Non-clear cell types are more aggressive when associated with metastatic disease as opposed to when localized. They're more likely to have nodal positive disease and more likely to have sarcomatoid features, which are all poor prognostic signs. Finally, tumor grade and the presence of sarcomatoid features predict a poor outcome in these patients. Finally, laboratory factors associated with a worse prognosis. The first three, of course, are from the MSK model, looking at metastatic renal cell patients. The last three have been reported in several retrospective reviews to possibly predict a worse prognosis. So we'll talk a little bit more just to summarize it all at the end there. We'll move on now to immunotherapy for metastatic renal cell carcinoma. So there's multiple different modalities investigated in immunotherapy for these patients. I just want to focus on interferon alpha and interleukin-2, the two most mainstream ones. Most of the continued interest in this field is in combination therapy with targeted agents or with tumor vaccines and stem cells. So interferon alpha first, biological cytokine. Its effects, it has a lot of different effects that may be anti-neoplastic, including immunostimulatory effects, anti-angiogenic effects, and direct anti-proliferative effects. It's given either intravenously or subcutaneous in one of 3 dose protocols. Highest response rates have generally been in the intermediate dose range with dose-dependent toxicity. So most clinical trials and most uses of interferon alpha sort of are between the 5 to 10 million unit range or in the intermediate group. Side effects are primarily flu-like syndrome, which the majority of patients will get. There are a few grade 3 or grade 4 complications. So interferon alpha has a fair amount of evidence behind it. A systematic review was done by the Cochrane group looking at interferon alpha versus a control. They demonstrated there is a small survival advantage with interferon alpha. The relative reduction in risk of death was about 2/3, and approximately 15% of patients will respond to it. However, it's very rare to get a durable response with interferon alpha. So the next question is, can you predict the people that will respond to interferon alpha? And the risk factors from the MSK model again come into play. If you look at the bottom there, median survival, this was generated from MSK data. If you have 0 of the prognostic factors and are treated with interferon alpha, your median survival is going to be around 20 months. As soon as you start to have risk factors, though, your survival plummets. So interferon alpha was previously the gold standard for metastatic renal cell carcinoma because of this small but demonstrable survival benefit. Of course, the clinical trial head-to-head with sunitinib versus interferon alpha has sort of surpassed that as the standard of care. We'll talk a bit more about this trial later, but just in summary, progression-free survival was significantly longer with sunitinib. There was an objective response much more frequently, and the sunitinib patients had a higher quality of life versus interferon alpha. Interleukin-2, one of the first agents that was FDA approved for treatment of metastatic renal cell carcinoma. Again, the biological effects, immunostimulatory and direct anti-cancer effects. Initial approval of this was based on 7 phase 2 trials with a total of 255 patients. They were treated with high-dose intravenous IL-2 and given up to 5 cycles of it if there was evidence of response. And the important thing to know about IL-2 is that there is a chance of cure with this treatment modality. From the 255 patients, there were 7% of patients who were complete responders with up to 10-year follow-up. 8% of patients had partial responses, and the median response duration was 54 months, or just under 5 years. So if you look at this Kaplan-Meier survival curve based on only the patients who responded, you can see up to 130 months there. There's still survival is basically leveled off at around the 40% mark, and those patients are probably cured of their disease. However, median survival was only 16 months, and it's similar to an equivalent untreated population. There are few well-designed randomized trials looking at IL-2 simply because of its toxicity. If you look at all patients in that phase, from that phase 2 data, the survival curve is pretty similar to patients that are untreated with IL-2. So it doesn't necessarily confer a survival advantage to the general population, but a small proportion of patients will be cured with treatment. The main downside to IL-2 treatment, of course, is its toxicity. It can be quite significant. High-dose therapy carries a risk of capillary leak syndrome, requires an ICU setting, a specialized cancer agency. Over 50% of patients will have some sort of hypotension, many of them hypotension refractory to vasopressors, thus making it a fairly toxic treatment to endure. There's lots of interest in trying to reduce this toxicity by using a low-dose regime, using subcutaneous IL-2, or combining it with interferon alpha. And 2 large trials, one out of the National Cancer Institute and one out from the cytokine working group, both investigated this. As you can see in the red, however, high-dose IV interleukin-2 still has the best chance of cure, which is basically the main indication for using it. Partial responses and complete responses are still significantly better compared to the low-dose or combination therapies. The next question is, can we predict who's going to respond to IL-2? Good risk patients are have the best chance of cure, so that's going to be primarily patients with less than one metastatic or only a solitary metastatic site, a prior nephrectomy, good functional status. Second factor is good risk pathology, so clear cell carcinoma would be the main one. And finally, the most exciting development in this area has probably been the carboxylic anhydrase 9 staining. Staining positive for this seems to predict tumors which are going to respond to IL-2. There's been some models generated from retrospective data that have shown that you can predict 35 to 40% response rate based on good prognostic factors and carboxylic anhydrase 9 staining. So in the future, that'll probably be where most of the research is looking at predicting patients who might benefit from this IL-2 therapy and combining it with targeted therapy. So other conclusions sort of from the data, I won't go into these in detail. Basically, switching cytokine modalities doesn't change the response. So if you fail interferon alpha, you shouldn't be switched to IL-2. And secondly, it's generally not that effective in intermediate and poor prognostic patients. They're going to have a poor outcome no matter what, and using immunotherapy in this group is generally not undertaken. So just to summarize this, it's a little bit confusing sometimes, but immunotherapy is basically considered in good risk patients. Interferon alpha has demonstrated a small but definitive improved survival. It's rare to have a response greater than 1 year, and it's being supplanted with targeted therapies now. Interleukin-2, a small proportion of patients will have a long-term remission with high-dose therapy, but there's no overall improved survival generally. The future in immunotherapy will be predicting which patients may have this long-term remission or this cure with interleukin-2, and looking at combination therapy with targeted therapy. So moving on to the last topic, targeted therapy. There's over 20 agents out there in various investigational phases looking at their effectiveness in targeted therapy for metastatic renal cell carcinoma. I'm going to talk about some of the trials, or the main level 1 evidence for some of these, mainly sunitinib, sorafenib, bevacizumab, and temsirolimus. So, targeted therapy, you can see the different targets in the pathway, in the cellular pathway, leading up to HIF activation. Bevacizumab is an antibody that binds VEGF. Sunitinib and sorafenib, you can see in the top corner there, and temsirolimus is an mTOR inhibitor. So even though sunitinib and sorafenib are very similar, there are some important differences in their cellular targets, which may lead to differences in their mechanism of action. We'll start with sorafenib, an oral tyrosine kinase inhibitor. It targets VEGF receptor, platelet-derived growth factor receptor, as well as the other targets from the previous screen. Adverse reactions from sorafenib are generally cardiovascular in nature. So these include MI and hypertension, cutaneous, hand-foot diseases and rashes, and finally general GI upset. Evidence for sorafenib was published in the New England Journal of Medicine in 2007. This was a large randomized controlled trial of 900 patients with metastatic clear cell carcinoma. The important thing to understand about this group of patients is that it's a group of patients that had failed previous systemic therapy. Almost 80% of them had been treated with some kind of cytokine therapy previously. It's generally good risk patients with a high functional status and low to intermediate risk factors. The primary endpoint was survival, secondary endpoint progression-free survival. The important thing that happened with this clinical trial was that at the interim analysis, actually, because of the benefit of sorafenib and the use of placebo in the other arm, they actually allowed crossover of patients from the placebo group to the sorafenib group. So this somewhat obscured the survival data and makes it hard to actually judge true survival benefit. and the actual statistical analysis in these patients didn't show a significant difference in survival. And you can see there near the end of the survival curve, for survival, they tend to converge, which is probably a function of the patient crossover. Progression-free survival, again, was statistically different. And again, you can see near the end of the trial with the crossover, they did begin to converge. At the bottom, you can see response rates. Important things to note, sorafenib had very few complete or partial responses, the majority of which were partial. It doesn't appear to be something that's going to cure metastatic renal cell carcinoma. However, if you look at the number of patients with stable disease versus placebo, there's a significantly higher number of patients now with stable disease and significantly less progression. So it does tend to control disease. Future questions for sorafenib. These have been investigated in phase 2 trials and will likely be worked into upcoming phase 3 trials. Actually, a head-to-head comparison with interferon alpha. Again, this was done with sorafenib versus interferon alpha in good risk patients. They found higher quality of life in the sorafenib patients. However, disease-free progression was about the same. A second study looked at dose escalation to see if we can get away with an actual higher dose of sorafenib, and they found that toxicity profiles were similar, and there was a higher objective response rate in these patients. However, median survival is still only 11 months. We'll talk a little bit more about all of these at the end and sort of sum up where we're at with their use and treatment. Sunitinib, again, inhibits VEGF, platelet-derived growth factor, as well as a variety of other targets. It's given orally. Adverse reactions, again, more likely to have problems with hypertension in terms of cardiac risk factors, and more likely to have hypothyroidism, actually. Sunitinib was evaluated in a head-to-head trial versus interferon alpha, 750 patients, published in the New England Journal of Medicine last year. Again, these are generally good risk patients. It randomized patients to either sunitinib, single cycle versus interferon alpha, with dose reductions allowed for adverse events. So this trial actually had progression-free survival as its primary endpoint. So as of yet, we haven't gone through a trial that has actually demonstrated a survival benefit. Again, results are similar to that seen in sorafenib. You can see complete responses, again, rare or non-existent in this case. Partial responses are a lot more common in the sunitinib group, as is lack of progression. Temsirolimus, an rapamycin analog that inhibits mTOR. Its role is primarily downstream of the phosphoinositol pathway, which regulates glucose within the body. It's an upstream activator of HIF1. Temsirolimus is given intravenously, and adverse events are primarily due to the mTOR inhibition, which relate to hyperglycemia, hyperlipidemia, and anemia. This trial looked at 600 patients with metastatic renal cell carcinoma, and the important thing about this trial is temsirolimus was actually studied in poor risk patients. So these patients had a lower performance status than was allowed in most of the other trials. Brain mets were even allowed. They had to have had no previous therapy, and they were randomized to either temsirolimus alone, temsirolimus at a lower dose plus interferon alpha, or interferon alpha alone. So looking at the population, the important thing here is this was the first drug to target in a phase 3 trial, a significantly different population that had been left out, mainly those with extremely poor risk features. So the majority of these patients had a functional status that meant they were only able to basically do their activities of daily living. Only 2/3 had actually had a previous nephrectomy, and 20% had non-clear cell cancer with poor prognostic features. So looking at overall survival, which was the primary endpoint, this is the first trial to actually demonstrate a difference in overall survival. The temsirolimus alone group actually did significantly better than the interferon alone group in terms of survival. However, as encouraging as this is, we're still dealing in terms of months of life as opposed to years of life. And finally, bevacizumab, a humanized antibody that binds and neutralizes VEGF. Again, a large randomized trial, phase 3 data from almost 650 patients, generally good risk patients. are randomized interferon alpha plus bevacizumab or interferon alpha and placebo. So response rate was significantly better, 31% in the bevacizumab plus interferon alpha versus 13% in the placebo plus interferon alpha. Progression-free survival was significantly better. Okay, we're running out of time here, so I'll just go on to the conclusions. Cytoreductive nephrectomy. Based on the evidence we have now, it seems that it should be offered to patients that have a high functional status, clear cell subtype, a reasonable metastatic burden, reasonable renal function. If they don't have a reasonable renal function, consider nephron-sparing surgery, good systemic function, and a lesion that's considered resectable. And if it is considered amendable to LAP, that seems like a laparoscopic approach, that seems like a reasonable alternative as well. Other patients, this has been done anecdotally, and they're still sort of working on studies for this, would be considering systemic therapy first and then follow for a delayed nephrectomy. So in other words, if the tumor actually responds to targeted therapy, consider a delayed nephrectomy. And finally, metastatic disease is primarily treated palliatively. However, pulmonary mets, especially the solitary pulmonary met, should be referred for a surgical opinion. So a group out of UCLA tried to put together sort of all this evidence and go over it. The RAND UCLA Appropriateness Panel. It's basically an evidence-based review of the literature. The actual method they use has been shown to be reproducible, clinically consistent, and to correlate with clinical outcomes. They looked at over 100 different permutations for systemic therapy and 24 permutations for cytoreductive nephrectomy. So looking at their conclusions for cytoreductive nephrectomy, good risk surgical patients with limited metastatic burden are definitely appropriate for a cytoreductive nephrectomy. Even if they have extensive therapy or extensive metastatic disease, it's appropriate. And if you're planning targeted therapy, it's appropriate, as long as they're good surgical risk patients. If they're poor surgical risk patients, it's generally uncertain or inappropriate. Cytokine therapy, interferon alpha demonstrates a survival benefit. High-dose IL-2 presents the only therapy we have so far that has demonstrated long-lasting. Perfect. So just to finish up the appropriateness here, so cytokine therapy, IL-2 can still be considered for good prognostic patients without previous immunotherapy. As Dr. Wright said, it's a very toxic therapy, and hopefully in the future we'll be able to target the population that's actually going to respond to it, as opposed to having to apply it to patients who may get no benefit from it. Patients who have had previous immunotherapy, further cytokine therapy is inappropriate. So targeted therapy, patients without previous immunotherapy, sunitinib and sorafenib are appropriate for good and intermediate risk patients. Temsirolimus is appropriate for poor risk patients. And finally, patients with previous immunotherapy, sunitinib and sorafenib are rated as appropriate. Obviously, sunitinib, due to the trial design, would probably be considered first line for patients without previous immunotherapy. Sorafenib, perhaps, for patients without or with previous immunotherapy. Future directions, just briefly. Obviously, there's a lot of interest in combination therapy, combining targeted therapy with cytokine therapy. These are various phase 2 and 3 trials that are recruiting right now, looking at various combinations. Stem cell transplant for metastatic renal cell is one of the areas in the immunotherapy field that is still generating a lot of evidence. Basically, you induce a graft versus host disease against the tumor. The largest group there, 124 patients, had a response rate of about 30%. Still needs further investigation. And finally, of course, another exciting area that's undergoing a lot of investigation is adjuvant therapy for high-risk renal cell cancer. So you have someone with a large primary tumor, and you want to try to eradicate the micrometastatic disease that is going to come back in about 30% of these patients. That's all. Thank you very much.